All right, if I can have everybody's attention, I think we'll get started here. So first of all, I want to thank everyone for taking time out of their busy weekends to come here for the conference this weekend. This is a really special meeting, and we're grateful for the speakers for taking time out of their busy schedule to come, but also all of you for coming and wanting to participate and learn more about facial pain. So I'm excited about this morning's first session. So today we're going to be talking about differential diagnoses of facial pain from different perspectives. And as a provider that treats facial pain, having a diagnosis is incredibly important. When you have the right diagnosis, things are easy. We have good treatment algorithms for different types of facial pain. I've found over 14 years that the biggest challenge in treating facial pain is actually getting the right diagnosis. And I think when you get the wrong diagnosis and you start down a treatment algorithm, oftentimes you can create new pain and you can make existing pain worse. And so I have to admit that what I've learned is that the most important thing in treating facial pain is getting that diagnosis. With that said, we've got an excellent panel or group of speakers today from different specialties, from neurosurgery, from dentistry, from pain. We're going to talk about the differential diagnosis and different pain modalities from their perspectives. So to kick things off, we have Alan Law, who's a dentist from here in town in Minnesota, and he's going to talk about facial pain from his perspective. We'll have him talk, and then there'll be questions for him, and then we'll kind of move through the talks as we go, and then at the end I'll have everybody come back up here, and you can ask additional questions if they pop up. So without further ado, Dr. Laws, if you want to please take the stage.
Thank you. Thanks for the invitation to speak today. I am an endodontist, and that means endo means inside, dont means tooth. So we deal with any inflammation or infection that starts in the tooth and then, of course, can spread to the surrounding tissues. And we diagnose that and treat that. And dental pain, and by some studies, is one of the 5 worst pains you can have. So we see patients at sometimes at their most vulnerable. I've done over almost 30,000 root canal treatments, which that statement alone typically kills conversations at cocktail parties. But you obviously are here because you want to learn more about this. So we'll get started. So the first thing I want to cover is why this is important. And you've just heard the reason. Because if we misdiagnose tooth pain, and patients come to me thinking they have a toothache, in most cases they do, thankfully. In some cases they don't. And if I were to do root canal treatment on patients that did not have a dental cause for their pain, I can not only not relieve their pain, but I can exacerbate their underlying pain. So it's important to get the right diagnosis. And to provide context, I'm reminded of this report that I saw a while back. So a woman reported as she was driving down the road, she saw a dog hanging onto a truck for its dear life. And later, this is a truck owned by a taxidermist, was seen at a Bass Pro Shop. So if we don't understand what's happening, we can misinterpret, and in case of pain, we can have very serious consequences. So typically, what are we dealing with when we have dental pain that may refer to other structures, but the dental pain is just coming from the tooth? First, we have sensitive teeth. Roots that are exposed typically can be more sensitive to temperature, hot, cold. Gum disease, typically you can see that, so you know where it's going to be tender. This typically is not very uncomfortable, but if it gets into the advanced stages, you can get an abscess. Pressure in that area can cause discomfort. An impacted tooth, if it's partially exposed, you can get an infection around that tooth, and that can cause pain in the posterior or the back of the jaw that can radiate to the ear. Inflammation of the tooth pulp, this can be from cavities, cracks, recent fillings like crowns, and this can cause throbbing type pain. It often refers from the lower jaw to the upper jaw. It can refer back to the ear and to other structures. Tooth decay, the deeper the bacteria get into the tooth, the more likely they are to cause pain. Most teeth die a painless death, so just because you have a cavity doesn't mean you're going to have pain. In fact, in most cases, you don't have pain when you have a deep cavity. If cavities get severe and the bacteria get from the inside of the tooth to the bone around the tooth, there's nowhere for that infection to expand, and that can cause pain in the jaw that can radiate to the ear and other structures. And then a cracked tooth. Typically, cracked teeth cause pain when you bite down on the tooth. You get a sharp pain as the tooth separates a little bit. Then when you release the pain, the pain can come. When you release the pressure, the pain can come again. So you get that sharp pain on release or on biting. And then there are other sources of pain that can refer to the teeth. So the patient feels or is reporting a toothache, but it's coming from other sources. The most common source of toothache, a non-odontogenic or non-tooth-caused pain, is joint pain or muscle pain that refers to the teeth. If you push down here in some patients, this is the masseter muscle, you can cause pain. If they're already having pain, it can radiate to the lower teeth. The upper part of this muscle, it can radiate to the upper teeth. If you push up into this area here, in the front part, it can radiate to the front teeth. So this is a classic referral pattern for these muscles, and we need to be able to rule that out. Patients can also come in with a toothache, but they can also have muscle pain because they've been guarding. So we may be dealing with two types of pain. And then, of course, the upper teeth, they're right below the sinus area, particularly the back teeth. If you have a lot of sinus pressure, that can cause pain in those teeth when you bite on them, when you tap on them, and when you push on this area. And then the classic trigeminal neuralgia pain is that sharp shooting pain that may feel like it's a tooth, but it's often triggered by things that are not related to tooth function, like temperature. It's often a breeze in the face or touching the skin. So we need to be able to understand all of these and rule these out, or rule tooth pain out if we suspect these conditions. So what is our goal of endodontic testing? Either to confirm it is a tooth or to rule out teeth before the patient presents for another evaluation. So what are we looking at? We're looking at the patient history. What's the patient reporting? Is it a typical pain that's by teeth, so it's triggered by hot, cold, or biting, the classic triggers for dental pain? Or is there no trigger at all? Is it a constant background pain? Are they reporting pain when wind blows in their face? Those are all key factors that we need to look in their history. We're also looking for pain elsewhere in the body. Patients that have pain in multiple locations are more likely to have non-tooth-related pain in the mouth, both presenting that way, but also persistent pain after treatment. Then we do clinical tests, and I'll go over those in a little bit. We do radiographic imaging or X-ray imaging, and part of the clinical tests involve pulp vitality, or is the tissue inside the tooth alive, and if it is alive, is it healthy? So for the patient history, I already mentioned we look at the onset. What triggers the pain? Was it a recent restoration? Was there a recent trauma in the area? Do they have a deep cavity that was recently diagnosed? Did they get recent dental treatment like a cleaning of their teeth? And the quality of the pain. You heard earlier the descriptors for the pain that typically we won't hear lancinating, stinging, burning type descriptions for dental pain. Those are more associated with neuropathic type pain. We look at the triggers, hot, cold, and biting, and then we look at, is the pain localized or referred? And if they say it is localized, when we say if your jaw didn't hurt, if this muscle didn't hurt, would your tooth still hurt? And we can reproduce that with our testing. So let's look at some of the tests that we're doing. The first one is percussion. And this video shows how we percuss teeth. Now, obviously, if a patient's coming in and they say, I have severe pain when I'm biting down, we're not going to take a metal mirror and tap on their tooth. We're going to be using digital pressure or just a finger with light pressure to reproduce the pain. But in some cases, it's very subtle, and we do use the back of a mirror handle, push on the teeth. And typically, if the ligament around the tooth is inflamed, that tooth will be very sensitive to even light pressure. So that's the palpation test that can localize the pain. And next we have palpation. So this is when we pull back the lip and we press above the teeth. We're looking for any area where there's inflammation around the tooth and in the surrounding bone. You can see we're pushing up toward the end of the root. This is likely where the infection is going to spread out into the ligament around the tooth and the surrounding bone. And light pressure can typically be localized to one tooth. For example, with sinus pain, it's multiple teeth, so we can push anywhere along here and it hurts. That's more indication that it's not a single tooth, but more likely to be sinus pain. And then we do the cold test. This is one of the most reliable tests we can do, and it's often what patients present with when they have a toothache that has living tissue inside the tooth. So we'll use a couple different types of tests. This is just a frozen piece of obvious ice that we put on the tooth. The disadvantage of this is that it can melt and it can spray to the adjacent teeth or spread to the adjacent teeth. We can also use a refrigerant spray that we place on a cotton swab, place on a tooth. If the tissue has died inside the tooth, the patient won't feel the cold, and if the tooth is inflamed, alive and inflamed, you'll get this severe throbbing pain even after we've taken the cold off. So this is a really important test because this often is the type of pain that can be confused with other types of pain. When you get this throbbing, poorly localized pain, people might think it's trigeminal neuropathic pain, but it can be just dental pain. Why do we not rely on the patients? When patients come in and they say, I know it's this tooth, why don't we just trust them? This study that was done at the Ohio State University is a great example. So we placed cold, or they placed cold on teeth and said which tooth is feeling the cold. 64% of the time in the upper arch, the patients guessed the right tooth. Less than half the time in the lower arch do they get the right tooth. So we have to be able to test and see which tooth we're testing and then have the patients tell us, is this reproducing their chief complaint? In some cases, the cold test is not reliable, and we have to use what's called an electric pulse test. This puts a small amount of current into teeth, and we slowly increase the current, and you'll feel a buzzing or a tingling sensation in the tooth. This is particularly useful in patients that are older because the canal space gets smaller and smaller inside the tooth. The teeth become less responsive to cold, and this one tends to be more accurate, but it only works on teeth without large fillings in them because you have to find natural tooth structure to place the instrument on. And then if a patient reports pain to biting, we can isolate different parts of the teeth to see if there's a tooth that's cracked. And typically when we place this on here, very clever name, tooth sleuth. If you place it on tooth and have the person bite down and grind a little bit, they may be able to reproduce that sharp pain when they bite or when they release the bite. So this is useful in identifying cracked teeth. And then we're also looking for any signs of attachment loss around the tooth that might be associated with the crack. When you get a really deep crack in a tooth, the bacteria follow that crack into the bone, and then you can start to lose attachment, and you'll get a very narrow pocket around the tooth. And this can look for areas where you have deep pockets. It can also look for generalized gum disease, which may be tender for the patient. Interestingly, in patients that have neuropathic type pain, this can be very uncomfortable. Just manipulation of the soft tissues can be uncomfortable. So we have to be aware of that. It's also one of the signs that we may be dealing with something that is not just a tooth, but is nerve-related pain. Then, of course, imaging. We're looking for any etiology or a cause. Healthy teeth don't cause severe tooth pain. So we're looking for a cause. You can see in this area here, let me get my pointer out. This tooth here has a deep cavity, so that's a likely source of the pain. This tooth here is a deep filling that's getting close to the pulp tissue in the tooth. That could be a source of pain. This tooth has a crack that we can image, and we can start to see attachment loss down here, the bones being destroyed or backing away from where the bacteria are. And the University of Minnesota now has a dedicated dental MRI. It's the first dedicated dental MRI in North America, and it's only one of 4 in the world. And we have one where we're doing investigating, and we're looking at patients that have possible sources of inflammation that are causing the pain. And what happens if you have a lot of inflammation around a tooth that has pain, you can see this bright white signal that would not be visible on other x-ray imaging of the teeth. So this is a great tool we'll have, and we're learning more about how we can use this in the diagnosis of a differential diagnosis of pain. So what are some key factors differentiating dental pain from non-dental pain? Dental pain or endodontic pain from inside the tooth is typically provoked by stimuli. I talked about that: hot, cold, biting, tapping on the teeth. It's localized with testing in almost every case. In some cases, in early stages, it's very difficult to diagnose the pain, but typically over time, and by over time I mean within a matter of days, maybe weeks, it will localize to a tooth if it is a tooth pain. And then is there some cause that we can see? Is there something we can see on the x-ray, a cavity or a deep restoration that would be associated with that type of pain? Non-endodontic pain has non-dental descriptors for the pain: burning, tingling, and often this persistent pain. Typically, dental pain is triggered. It doesn't correlate with a specific tooth, so it may be here, it may feel like it's up here, it may move around, and then they have other tissues around the tooth that are tender, not just a single tooth. And then we're looking for other causes like neuropathic pain or muscular pain. So what would you expect in a dental visit when you're presenting with pain? You should be getting a good medical history, dental history as we talked about, Be very descriptive with your chief complaint. So what triggers the pain? What makes the pain go away? Or does the pain never go away? Is there always a background pain that is made worse by chewing, hot, cold, or does it make no difference whether you're eating? It's always there. And then you should expect a good dental exam, those tests that I described, and then a thorough explanation of what those tests mean and what are the next steps. So we've identified it as a tooth. Now you have the option of doing root canal treatment to remove the infection or inflammation inside the tooth, or extraction of the tooth, and then the prognosis for those. And then if there's other findings, so if you have a toothache but you also have muscle pain, explaining that we can manage this pain, but you'll also have to manage this other pain. So there may be what we call comorbidities. And then if we can't identify the source of the pain, you should expect a discussion about a referral to a facial pain or a facial neurologist to discuss the other options and diagnosis. So accurate testing leads to accurate diagnosis and the correct treatment. That's an important point that you've already heard. I want to reiterate that. These tests that we have can help differentiate odontogenic or tooth-related pain from non-odontogenic pain. Early diagnosis, the earlier we can treat dental infections, certainly, we can prevent pain, but also the prognosis goes up. If you don't treat a tooth that has an infection and the infection spreads to the bone, the prognosis drops for treatment, a root canal treatment, by about 20%. So once you know you have a toothache, it's better to get in early rather than waiting until something makes it worse. And then always consult a specialist if you have persistent or unclear sources for your pain. This is my email address. If you have any questions that I didn't answer here, or I don't answer later on if we have time. And thank you for your attention. Yes. Well, you can get MRI imaging that's not specific to dentistry, and that may be, it's not as precise, meaning we're not looking at small areas, you're not going to have the same level of resolution. So you can do that, but it's not going to be as helpful. And then, again, at the University of Minnesota, it's more in the research early phase. So I have sent patients over to the University of Minnesota if I'm trying to see if there's any inflammation around a tooth. This is but it's still early stages. Right, right. And it could be what we call a comorbidity. So she has two different things going on. Her condition makes her more likely to have pain associated with any dental inflammation. So what normally wouldn't bother other people might be more sensitive as a result of that. Welcome. Days.
Yeah, he can talk for days about that. I'm wondering if in the back, do you have access? Look at that. There you go. Oh, Abby, can you pull up Marshall's?
Let's see. Good.
They're pulling that up.
Okay.
It's really Marshall Holland here. Marshall actually on Thursday. You know. started traveling. So Marshall originally is from Illinois. To medical school. Traveled long and far for his residency. Iowa for his neurosurgical training, and then from there did both in Florida and then in Oregon. I'm suspicious that he touched by that had an impact on your career. I know that for a lot of young neurosurgeons, oftentimes in the previous grade on, and it's exciting to see young generation of the next grade up, and I think Marshall's so Marshall today is going to talk about facial pain. Without further.
Yeah, you'll see virtual influence my talk. Can you switch over to my computer, my input here, so I can have control of the PowerPoint? Okay. Yeah, if you should just switch over to the HDMI up here, I've got my own stuff. Okay, now we got control. Okay. Before I get started, I wanted to say it's an honor to be here. I think this is exactly what we need as a facial pain community, bringing together different walks of life, people who trained in dentistry, trained in neurosurgery, neuroscientists, patients, patient advocates. This is a multidisciplinary, in my mind, solvable problem. We just have to talk to each other. Getting care is often very disconjugated. So one of my missions and why I'm here is I want to be a part of this community that we're bringing people together from different disciplines. And as part of my mission as an academic neurosurgeon is I get the privilege of training the next generation of neurosurgeons. And I think we can do better. We can do better than it's trigeminal neuralgia, and if it's not, please go somewhere else. We can be more helpful to our patients, and that starts with listening. This talk that I'm going to give you is actually the talk I give to my residents before, as a primer, before they come to my clinic and get to see these patients. And at the end, I'm going to go through several cases, which is a normal clinic for me, and get to show you a variety of what we get to see at UAB, and then my residents get to see this, and then they get to go forth and have this knowledge. This also gives you a little peek into my brain, which I apologize in advance. Some things in there you may not want to know. But I do emphasize to my trainees, the most important thing we can do with a patient is sit and listen. Facial pain, when I sit down with a patient, I tell them the hardest thing with this whole deal you're going through is diagnosis. And you're going to hear this from every speaker. Diagnosis is everything, because you can get down the wrong road very quickly, and it's very hard to come back from that. And just to quote one of my mentors, and this one doesn't come from Birchall, but the surgery is easy. The thinking part's hard. These are my disclosures, none of which really relate to this talk, because this is all about diagnosis. This is a normal patient that I would see in my clinic. Some of these symptoms may sound familiar to you. The 58-year-old man, left facial pain, stabbing, very lancinating pain, one may say. And it comes and goes. And now it seems like it's out of control. And we got to diagnose them. Here's the agenda. And it's important to remember when I think about facial pain that there's more than just the nerve. The nerve is important. I'm a neurosurgeon. This is what I'm thinking about. But there's other things. Muscle, connective tissue, dental things that I'm not as familiar with, but I know they're out there. But we have to be thinking about them even though this patient's sitting in a neurosurgeon's office. Now, to quote my mentor, Dr. Birchall would often say to a patient, the most important thing we're going to do today is try to get to a diagnosis. Diagnosis is everything. And it's, for us, it's all about the history. What's going on in this patient's history that's brought them here to us? And Birchall proposed this facial pain classification. He obviously has a big influence on me. This is what's in my mind when I'm seeing a patient. Classic type 1 trigeminal neuralgia, where episodic pain predominates. Type 2, constant pain predominates. What makes looking through the literature difficult is this used to be called all sorts of different things, atypical facial pain. This may be another diagnosis entirely, though, because this facial pain classification was written many years ago, and the science gets better. We get better at diagnosis, we get better, and we should. But we should be able to revisit this. And then secondary facial pain that we're looking for as neurosurgeons include this long list. And these are the main things that are in my head when I'm trying to see a patient. In trigeminal neuralgia, this is our classic sharp pain. Patients tend to remember that first event. You know, I was at the carnival and I took a bite of that ice cream, and oh my God, that was awful. And I thought, ooh, hope that never happens again. And then it does. And they start to figure out these events or things they can do to trigger it. And some of the key things I'm looking for in the history when I'm talking to patients are those pain-free intervals. There are times where the pain just goes away. It goes away for days, weeks, months, and then it comes back. Almost always unilateral. And I'm always looking for what usually is the nail in the coffin with these patients. I forgot that your slides are not synced up with mine. Is the response to medications. What I'm looking for is a light switch response. When I got to the right dose of that carbamazepine you put me on, my life went back to normal. We think there's the ignition hypothesis is because this is a triggered event, you need an input to provide the pain. That could be drinking a cold glass of water, wind on the face, and that sensory input, somewhere in the system between that input and the brain, causes a jumping of the signal. The brain interprets that signal, bing, 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 bing. You just got hit by a lightning bolt, you should do something about that. And that's why we think about this trigger. That trigger is so important. And there's multiple options for this. There'll be other talks that focus on the surgery. Type 2 was defined as intermittent pain, but also an overwhelming constant pain. And this is where I start to think we may be misdiagnosing this. Perhaps trigeminal neuralgia isn't a spectrum. And this is the way I think now, being in practice almost 4 years, is it's either trigeminal neuralgia or it's not. Stop trying to make everything trigeminal neuralgia. Go search for the other thing. So I think this is most likely some other differential diagnosis that we should be going after instead of calling it trigeminal neuralgia, doing a surgery that helps a little bit, but not the way we see classic trigeminal neuralgia patients. So I don't think we got to the root of the cause of the pain. That's that. It's not trigeminal neuralgia. TMD, which you'll hear more about throughout this conference, and many of us have interacted with this syndrome, is a chronic pain syndrome, not unlike chronic back pain, which is another thing that I treat as a functional neurosurgeon. And this is much more common than trigeminal neuralgia, and so we need to be on the lookout for it. This kind of falls under these muscle, connective tissue, chronic pain that morphs into a chronic pain disorder. And it's a mimicker, and I think this is what gets many clinicians confused, is that you can have sharp stabbing pain from TMD, but it's usually in the setting of a strong background, constant aching pain. And trigeminal neuralgia goes away, pain-free intervals. These other myofascial symptoms can leave the face. Trigeminal neuralgia doesn't leave the face. The patient talks about pain behind the ear, in the neck. I'm thinking red My antenna goes up, there's something else here. Now, it doesn't mean you can't have trigeminal neuralgia and TMD, but we've got to address both if you do. And so we need to be thinking through this. And this, anytime I hear bilateral, something else going on here. The other thing that I've found interesting as I've gone through seeing more of these patients is we start to find more exam findings. In trigeminal neuralgia, the history is typically very clear. It's a strange history, but consistent. And they usually don't have any exam findings, but in many of my TMD patients that I identify, they have these other subtle clues, and it's just this buildup of evidence that I'm missing something, I should be looking at something else. And often these patients will have a history of a jaw injury or a jaw surgery or a history of bruxism. Something about overusing these big, powerful muscles that we develop to crack nuts, that those things can hurt. And I will often get these patients to, I've identified 2 people in my region that I trust to start breaking that down. I wish I had more folks like you around me. Symptomatic trigeminal neuralgia was defined by Burchell as trigeminal neuralgia in the setting of multiple sclerosis. Why set these people apart from classic trigeminal neuralgia if they present the same way in terms of their history? And it's because they're a little different. Their pathogenesis seems to be due to the demyelination, which allows the jump of the signal. And thus they become a little bit harder to treat. Our treatments don't work as long. I tend to not proceed with microvascular decompression for these patients because their treatments are not as durable. They come back, and so we need to have something that's more repeatable. Again, I'm trying not to go too much into treatment because those will come later. Another thing that I've seen more frequently, which is we're trying to spread the word about too, is postherpetic neuralgia. These are patients that have a zoster reinfection or shingles on the face. Most patients you can treat them with antivirals, it'll go away, they feel better. Some are left with a lingering, constant burning pain. And those poor patients are different. We need to think through, if medications don't work, destructive procedures, controversial, but I typically lean on stimulation for them. And it's again kind of thinking through the way we would look at a chronic pain, regional pain syndrome patient. We have a nerve that's sending a pain signal and we need to tamp it down, turn it down with modulation. It's not a cure, but it sure makes people's lives a lot more livable. Trigeminal neuropathic pain is then given to a patient in their history who had damage to a nerve unintentionally. And the reason, again, this is important is once we think through and can get to this diagnosis, how do we approach them surgically? These patients, I also tend to lean on stimulation rather than a destructive procedure. That's versus deafforation pain, or also known as anesthesia dolorosa. This is one of our most feared facial pain syndromes because we don't have great options. The things that we're working on in terms of treatment, that's happening in the other room, the research room, because this is where we're heading. This is the frontier. And they present differently. Numb, but pain. And the way I approach it as a clinician, without leaning into the research side, is a multidisciplinary approach. Now, how can we manage this pain? Some people have sought out motor cortex stimulation. One of my friends in the other room is working on that, and that's had mixed results. So there is hope for this. What we try to do as a clinician, though, is try to avoid this. And that saves, what I like about this classification is saves atypical facial pain for less than 1%. Suspicion of psychogenic pain. And because atypical facial pain started getting thrown around in the literature, especially anything that wasn't type 1 trigeminal neuralgia. So this should be something that's very rare. And there's all sorts of other things out there. Endless. So this is when I walk into a room and I see a patient, I've got three major questions that are going to go through my head that I'm trying to answer. And it may take me the whole 45 minutes to an hour to figure this out in my head. Question one, is this trigeminal neuralgia type 1 or not? Because I have my own surgical algorithm, pros and cons to talk to patients about. Question two, it's not trigeminal neuralgia type 1. Do I suspect TMD? Simply because it's so prevalent in a patient that winds up in my clinic. Because if it is, I need to make sure I don't operate on this patient, unless they happen to have both, and get them to the right person. And then question three, if it's not one of those two, what else is it? And what treatments do we have that I could offer or get to the right person? Just a couple of cases to show that what's it like in a normal week with me. This is a 56-year-old woman who had zoster on the left V1 up here above the eye and V2 in the cheek. Treated with antivirals, everything went away, but was left with this constant burning, stabbing pain in her head to the point where she couldn't even brush her hair. And despite multiple interventions by other pain management treatment, could not obtain satisfactory relief. So this is a post-herpetic neuralgia patient, and we did stimulation for her. And I'll never forget when she came back to her 6-week follow-up. When I first saw her, she was so sensitive, she wouldn't put makeup on that side of her face or brush her hair. She was completely put together. It was pretty amazing. And then this is a 35-year-old man that I saw in my clinic who had facial pain for 3 years, pain above the left ear, and then a secondary constant burning pain. Didn't have a great response to medications. This is a patient I'm starting to suspect TMD. I got this patient evaluated by one of our OMFS colleagues, or one of our dentistry colleagues, and he had exam findings. So it's all these little clues. And last one, or two more. 68-year-old man. This patient now has constant facial pain and numbness, had undergone 2 prior destructive surgeries. This is a patient that has now dysesthetic, meaning touch pain. I'm worried about deamphoration pain. I want to get this patient connected to our multi-management pain colleagues. What I don't want to do is operate on this patient because I feel I could only make him worse. And then this is our first patient from the clinic. This is the one I'm looking for. This is the person that I have lots of treatments for. This is a trigeminal neuralgia type 1 patient. But it's important to remember, and this is what I stress with our residents, these are not all the patients that are coming to your clinic. Keep an open mind. Keep your diagnosis wide. Diagnosis is everything. The other thing I try to emphasize is you have to go in with a blank slate. This is a facial pain patient. We should not take this diagnosis that was referred to us and say, okay, this is a trigeminal neuralgia. No, this is a facial pain patient until we've done our evaluation. And history is everything. So having that framework and those questions only improve our ability to treat our patients. And we need to be worthy to serve our suffering patients. And that is only due to 2 things: listening and constantly improving. That's why we have these meetings. And saying that, thank you so much for having me. I'll be around the whole meeting. I think I have a lunch and learn thing too, so I'm happy to talk about things further. This is just the appetizer.
As we kind of get switched over, I'll invite Abby Metzler up next. As we kind of get switched up, are there any quick questions for Dr. Holland? Dr. Marshall here? Or otherwise, we'll invite Holland back up at the end. For the questions over here, as we get set up, can you just, while we're doing this, can you get Dr. Metzler's talk up? Go ahead.
Yeah. Yeah, and it's not uncommon. I wouldn't say it's common, or it's not unusual to see a patient who's had trigeminal neuralgia type 1, and you undergo treatments, and they help, and then you can start to develop some type 2 symptoms, and I believe that's due to almost everything we do for trigeminal neuralgia is in some ways destructive. There's some intentional damage to the nerve, or unintentional. And that nerve isn't just a sensory nerve. It's a motor nerve too, and it's innervating those big muscles, the muscles up here, the temporalis muscle, the masseter muscle, the chewing muscles. Those can get weak with time. And so seeking out, so I have patients like you. Those are the patients I work with our dentistry colleagues and work with physical therapy to help try and strengthen those muscles. Because they're, not to try to sound like a chiropractor, because I'm a neurosurgeon, but they get out of balance. If you have one big muscle that's stronger than the other, it's kind of like low back pain. You're always leaning. That one has to work harder, it hurts. So I usually start with that, and then working with our dentistry colleagues, there's some other, I found a couple that are more interested in, TMD is much more of a spectrum than trigeminal neuralgia, because there can be an inflammatory component too. So tamping that down as well can help with what I've found is that seems to be a big component of the sharp pain that throws off clinicians. The muscle's inflamed, you touch it, it hurts. But yeah, that constant background aching pain, one man's opinion, I think that's a weak muscle, and it's a muscle that hurts. Yeah.
All right. So our next speaker is Dr. Abby Metzler. So Dr. Metzler did her medical school in Toledo, Ohio, and then from there did her residency here at the University of Minnesota in neurology, and then went on to the Mayo Clinic to do a headache fellowship, and then has come back and has joined our facial pain clinic and center here at the University of Minnesota and specializes in the treatment of headaches and then also in facial pain. As I was kind of thinking about your course and whatnot, it's a little bit humbling because I realized that you started your residency. I had been already on faculty for a while. You've done all of that, and now you've still been in your practice for 6 years. So it's humbling, but it's really exciting to watch people like yourself and David Darrow in the room next to us who have gone through the training here at the university and are really in a point in a time where you're accelerating your own career in facial pain. And so it's really a privilege to have you and look forward to you talking about diagnosis of facial pain from the perspective of a neurologist. So thank you.
Thank you for that very warm welcome. I'm excited to be here. I'm Abby Metzler. I'm a headache neurologist, and I'm going to give the neurologist perspective to face pain. This is my contact information as well. I do have a Twitter page if anyone does Twitter, where I kind of do updates on headache care. Okay, and how do I advance that one? Okay. So face pain can affect anywhere in the face, obviously. So we think about more than just the top of the head when we think about headache. Headache really can include anything above the neck. So it could be the jaw, it could be the cheek, the eyes, the nose, the ear, anywhere. So we think about headache disorders, it can be a really broad category. There can be different types of pain and the different pattern to the pain. And as you've heard already, these elements of the history are the most important thing to getting an accurate diagnosis. So we do encourage patients to have a headache diary or a headache journal where you actually track your pain. It's really hard when you ask someone, like, what was your pain like 3 months ago? It's impossible to know. So really having a diary or a tracker can be helpful. And it matters. So if we can get an accurate diagnosis, as you've heard, we have better treatment options. I'm going to do my talk today in patient cases. So I have 5 cases. This is not an exhaustive list, but 5 things that I think we see a lot of or are important to know about. So case 1 is it comes on like lightning. So this is Anna. She's 58, and she has sudden, sharp electric shock-like pain just on the right cheek that triggered by brushing her teeth. When I do her neurologic exam, it's completely normal. You can probably guess this one from the previous talks. This is trigeminal neuralgia. So this is that pain coming from the trigeminal nerve, really brief, severe pain that's triggered. And we heard that type 1 is that trigger is really important. And typically there's a normal exam with those common triggers that sometimes you can bring out in the clinic and even confirm. The trigeminal nerve has different branches. You can see here some of the different colors that designate the main branches. So V1, V2, and V3. By far the most common are in V2 and in V3. And you can also see on the right side that there's other branches here. So it's also possible outside of trigeminal neuralgia to have other types of neuralgia. So for example, supraorbital neuralgia, you could have auriculotemporal neuralgia. So any one of these branches can be painful. So sometimes we even target it more specifically depending on the case. The treatment for trigeminal neuralgia is really medication first. So the carbamazepine and oxcarbazepine are the gold standard. There are other second and third line medications that can be tried as well, but this is where we start. And as you heard, this is usually very effective in the right patient. There are other things that can be used too, nerve blocks, procedures, surgeries, and good control is often possible with the right treatment plan here. Case 2, my whole face hurts and I feel sick. So this is James, he's 42. He has throbbing pain on one side of the face, but also the forehead, and it goes on for hours. So at least 4 hours, if not all day after this starts. He also gets nauseous, sometimes actually vomits from this pain. Also is very sensitive to lights and sounds when it's going on. So he wants to go hide in a dark room, put the covers over his head. He also describes an aura, which is for him is like a flashing lights on one side of his vision that gives him a warning that this is coming on in the next hour. He has migraine. So a lot of people don't think of migraine affecting the face, but for some people it really does predominantly affect their face. It can mimic other things too, like dental pain or sinus pain that we've heard about. Typically, this is a throbbing or pulsating pain is the quality that's most common, associated with that sensitivity, so sensory sensitivities, lights, sounds, smells, motion. These people are very sensitive to sensory input. Can have nausea and vomiting as well. And some people get aura. Most people with migraine do not get aura. So I just want to make sure we don't throw out that migraine diagnosis. If someone doesn't get aura, it's probably still migraine. And this is not caused by sinus infection. So one common misconception is someone who gets sinus infections, and those sinus infections come back every month, and they always get more antibiotics, and no matter how many CT scans you do, there's never an infection there. That's probably migraine. This is a chart of what a typical migraine attack is like. So you can see that migraine is more than just the headache or the pain part. So this starts with a premonitory or a prodrome phase, where many people will describe being fatigued, yawning more, have trouble concentrating. Sometimes they'll have autonomic symptoms. So that's like redness or tearing of one eye, things like that. That can come on with other types of headache as well, which we'll talk about. The headache part itself lasts between 4 and 72 hours. And then afterward, people kind of get this hungover feeling where they're kind of drained and tired the next day. So this whole thing can last a day, 2 days, 3 days, depending on the case. So that's a migraine attack. Migraine attacks are treated with triptan medicines. Those are the rescue medicines that we have for migraine. Also, NSAIDs, Tylenol, over-the-counter medications are sometimes used, and like in this case, people want to rest, so sleep can also be helpful. If they're happening very frequently, or there are people who have baseline pain all the time, the preventative treatments are also added on. So these are of many, but there are, I listed some of the first line ones: propranolol, topiramate, amitriptyline, And there's some newer injectable treatments for migraine now too, botulinum toxin injections, CGRP inhibitors as well. Other things for migraine, it's about avoiding triggers in a lot of people. And so lifestyle tips, the more that you can keep your brain in a routine. It likes to know when to go to bed, when to wake up, when it's going to get food. So the more you can keep your routines, the better people can be as well. Okay. Case 3, pain and tearing around my eye. This is Maria, she's 36. She has severe pain around her left eye. It's associated with tearing, and the eye turns red when you see it, when it's happening. This happens about the same time every day, and it lasts about an hour. So it's very severe when it happens, but then after that hour, she's fine, back to normal. This is cluster headache. Cluster headache is one of the trigeminal autonomic cephalalgias. This is a category of headache disorders, of which cluster headache is one, and I have a graphic on the next slide I'll show you. But by definition, it includes the trigeminal system. So remember those 3 main branches. So the pain is typically around the eye or in the forehead or face. There are autonomic symptoms. So there's redness or tearing. There can also be flushing or swelling of that side of the face. And it happens associated with your circadian rhythm. So there's a timeness to this. So someone will say, I have an attack every day at 4 p.m. Or I had a college student who came in to see me recently who's like, I miss every 10 a.m. lecture when I have a cluster attack. And for 6 weeks, he cannot get out of bed that hour. Or he can't get out of bed, he's just not going to class. So here is the algorithm for the trigeminal autonomic cephalalgias. These are varied based on the duration, how long the attack lasts, as well as how often it happens, how long it lasts. So if it's going on for just a couple seconds up to a minute, and it has 1 up to hundreds of times a day, this is Sunctor Suna. These are the short-lasting ones. If it lasts for minutes and happens between 5 and 50 times a day, paroxysmal hemicrania. Cluster headache is from minutes to hours, so 15 minutes up to 3 hours, like our case, 1 to 8 times per day. And hemicrania continua, which is, as the name suggests, continuous. And all of these affect pain on one side of the face or head and always have those autonomic features with it. So this really is what like a headache specialist, this is one of the things that we do a lot of is these trigeminal autonomic cephalalgias. These have very different treatments as well. So oxygen is actually one of the main treatments for cluster headache. So having a high flow oxygen tank that the patient can put on during the attacks is very effective. Or using some of those triptan medicines like we talked about for migraine, the fast-acting ones like the nasal sprays or the injectable one. There's also different preventatives that can happen. So in a patient who has this happen, let's say for 6 weeks out of a year, they might choose to be on a preventative to help that not happen every year. Or maybe this happens 3 times a year. So verapamil, lithium, some of the CGRP blockers are being studied in cluster headache now as well. And nerve stimulation has some data too. Case 4, it hurts and my face feels funny. Daniel is 63, has constant burning jaw pain, and the lower lip feels kind of numb too. And when you talk to him more, that he has had shingles affecting that area in the past. As we heard in the last talk, this is called postherpetic neuralgia. For most people who have shingles infections, the pain that goes along with it goes away. But for some people, it does stay and can last for months or even years. This is something that happens after someone has the chicken pox and then reactivates into shingles later on. And this is often seen in older adults just because that's who gets shingles, right? Here's another look at the trigeminal nerve. You can see that sense, the ganglion there. The ganglia is just where all the nerves come together. This is where that virus lives in our body and then it reactivates when we have the shingles. So the treatment, and what's important, is that people get vaccinated against shingles. Even if you've already had this happen, it's still recommended you get vaccinated against shingles. Medications, we think about neuropathic pain medicines, so gabapentin, pregabalin. Some people use topical treatments like creams or lidocaine if that's practical. And this can get better over time. So like I said, it can go on for months or years, and I think it's worth treating if someone's having it go on for a long time, but this can get better. Right, case 5. It hurts when I chew. This is Helen, she's 71. She has jaw pain when she's chewing, and her scalp is also tender. She also has a kind of a new headache on that side and describes some worsening of her vision in her eyes. This is giant cell arteritis. So this is a little different type of headache disorder. This is caused by inflammation in the arteries. We think of this when we see someone who's over age 50 who has a new headache on one side, specifically if they have jaw pain, and then we always hope they don't, but sometimes they'll have vision symptoms as well. This is important to diagnose right away because it can be an emergency. That vision change can become permanent, or the person can actually go blind. Here's an example of a fundoscopic exam in a patient with giant cell arteritis. So this is like taking a look through the pupil, looking at the back of the eye. I don't blame if you don't see a lot of these, but this is the back of the eye. Those red things are the arteries. The white part in the middle is usually like a crisp white circle, and you can see here it's really blurred, right? And so this is an optic nerve that has atrophy and damage from not getting the blood flow from this disorder. So this is abnormal. As we said, this is an emergency. It can cause blindness. So if we're suspecting this in someone, we start steroids right away. Many people have to be on steroids for 6 months to a year when they're on this. So it is important that we get treated right away. And biopsy is the way to confirm it. So we have our colleagues help us out by doing a temporal artery biopsy. So we actually take a chunk of the artery out of the temple and look at it under a microscope to confirm that these inflammation changes are there. Interestingly, like last month, the FDA approved a new JAK1 inhibitor that can treat this condition as well in combination with steroids. So you might hear more about that. And the treatment is really needed to prevent these complications. So the steroids usually help not only the symptoms, but also preventing that person from losing their vision. So putting it all together for these 5 cases, you can see that these are 5 different folks who showed up all with pain on one side of the face and the multitude of different headache disorders that can describe those conditions. Also, you'll notice that the treatment options are different in each category. So I'll reiterate what everyone else has said, that getting that right diagnosis is really important to getting the best treatment options. And so final thoughts, make sure you know the pattern of your pain and how it's changed over time. Writing a headache diary or headache journal can be helpful. Making sure you're seeing the right folks to get the best diagnosis. And if you need another opinion on face pain, think about your neurologist too. Thank you.
Questions? Shannon up as well as our next speaker. If you don't mind pulling Dr. Shannon's talk up. So Abby, that was terrific. You can usually judge the quality of a talk by the number of providers who are out there taking pictures of your slides. So I saw many. That was terrific and very helpful. Our next speaker then is Dr. Clarence Shannon. So Dr. Shannon did his medical school at the University of Chicago. He did his residency at the State University in New York, a pain fellowship at Emory, and then was at Walter Reed for many years, and then came to us here at the University of Minnesota now. It seems like 5 or 6 years ago. I'm not even sure anymore. 8 years ago. And since that time, he's become the division director in the Department of Anesthesia for pain, and then is now the associate dean of the medical school for strategy and innovation as well. But he's a close colleague of ours for the management of pain, obviously as the head of our pain group here. And we'll talk about differential diagnosis from his perspective. So thank you.
Sure.
Do you have your talk? Or?
Yeah, it's up there. I'm gonna. It's up. First off, I'd like to thank you guys for inviting me to be here. This is actually a great honor to be able to talk to this people in this type of forum. I want to tell you, I have nothing to disclose, but I'll start this out by saying the way that I was introduced to facial pain. I was a medical student back at the University of Chicago, and I was in the clinic with my mentor and hero, Dr. Terry Dallas. She was a pain physician who kind of took me under her wing. And we had a patient that came in. The lady was in her mid-60s, and she came in, and just on first inspection, she looked a little bit unkempt, but she came in the room, and she was distressed. And she said, I have these paroxysms of pain that just come out of nowhere. They're lancinating, they're sharp shooting. Sometimes I don't know if I'm going to make it. She told us that she'd lost a lot of weight. She looked unkempt because she said, I don't brush my teeth as much. I don't wash my hair. I don't comb my hair. I'm not eating, so I'm losing weight. And I was disturbed and perplexed by this, but I was even more perplexed when I looked at my hero and I could see that she was kind of deflated because it seemed like this was going to be something that was going to be very hard to treat. So we left the room. She told me, I think this is trigeminal neuralgia based on her presentation. And I said, well, why do you look so upset? She said, this is something that's very hard to treat, and we'll have to get a lot of people involved to help us treat it. And it's not something that might go away. So that was my introduction, and I'll tell you, facial pain is not uncommon. It affects approximately 10 to 25% of people worldwide. Twice as many women are affected as men. And sometimes I wonder if that's just because women will go to the doctors and guys are knuckleheads and won't go to the doctors. And it has a significant impact on quality of life, just as I've said. And many times, as in the case of trigeminal neuralgia that I've talked about, it will happen to someone in the 6th through the 8th decade of their life. So when I was a kid, when I heard something involved somebody that was 60 or 50 or just shrugged it off. But now that I'm in that age group, I roll my eyes and get a little nervous, but at least I can get my free coffee at McDonald's in the morning, so I guess it all evens out. I've distilled this slide into causes of what could be the cause of facial pain: dental infections, as we've already heard, trigeminal neuralgia, which seems to be the hero of the day. Everybody's talking about that. Temporal mandibular joint dysfunctions, sinusitis, migraines, and cluster headaches. And I say I've distilled that down because if you really look at the causes of facial pain, they're myriad. I put them in the categories of oral pain, extraoral pain, and the two categories, the two columns on the left-hand side are the things that I deal with most. So things that are neuropathic, musculoskeletal, or myofascial. Oh, gotcha, sorry. I'm so used to pushing this button in. Thanks. So, as I said, the two categories on the left are the things that I deal with the most. As you can see, and as Dr. Metzler has alluded to, we really, really need to use a multidisciplinary approach for this. We have to talk to people who are neurologists, because we want to treat headaches, otolaryngologists, so if people have sinusitis, I'm not the expert in treating that, neurosurgeons, so if they want to do a microvascular decompression, dentist, and then pain interventionalists. I think what's really important, and the reason why a forum like this is amazing, is that sometimes when we're siloed, we don't know what other people do. So it's kind of nice to know the things that are in the armamentarium of some of our colleagues. When I approach a patient that has facial pain, there are three things or three treatment modalities that I consider. So I consider pharmacologic therapies, non-pharmacologic therapies, and then advanced interventions. And when I think about pharmacologic treatments, and I have to keep this in my hand so I can remember to use it. When I think about pharmacologic treatments, I use a stepwise fashion. I like to use, I'm a big chicken. I always tell my patients and my residents that I try to start out with the things that are the least invasive, and we move up to the things that are the most invasive. So I will start out with non-steroidal anti-inflammatory drugs. I'll use analgesics that include opioids, but not opioids solely, muscle relaxants, anticonvulsants like oxcarbazepine and carbamazepine, and antidepressants. And one of the things that I like to do when I talk to a patient is say, not one of these medications will be the panacea. And it's actually very important for us to say, if I try a medication, I think the propensity of patients is to say, that didn't help at all, if it maybe only helped 10%. So I am very clear with saying, I need to know if it helped even just a little bit, because I look at this like an onion. We're gonna peel one layer off, and we are left with some other type of pain. We'll use another modality to peel the next layer off until we get to the core of the pain problem. Pharmacologically, and I think everyone has talked about this, like I said, trigeminal neuralgia seems to be the big winner for the day. So carbamazepine and oxcarbazepine are the things that I use first. They actually have a very good track record of treating trigeminal neuralgia, but they're not without their side effects. So, and the side effects can actually be pretty devastating. So aplastic anemia, liver disease. And so if you start these medications, it's really, really important to be followed up to make sure that there's no deleterious effects. Lamotrigine, I should go back and mention that those two medications actually can be used as monotherapy. And they can work for a while. Sometimes, and it's not very clear why, there can be some tachyphylaxis to it so that the medication doesn't work as well over time. Lamictal is another medication that can be used as an adjunct. These next medications would be used as adjuncts to therapy. And Lamictal or lamotrigine can be used. It causes some sedation. Sometimes I get a little bit nervous about it because it can cause a Stevens-Johnson syndrome, which is very rare, like 0.6% of the time, but I've seen it, and so it makes me really, really nervous. Baclofen is a muscle relaxant, so if somebody has a myofascial component of their facial pain, you can treat that with doses of up to 80 milligrams a day. It can cause some sedation. It can cause some weakness. If you decide to come off of the medication, then you have to wean off of it very carefully. Gabapentin always gets mentioned, and I always think it's like throwing a quarter into the koi pond. We hope it's gonna work and we're wishing, but sometimes it really doesn't work as well as we think it will. And for a lot of pain conditions, it hasn't been shown to be very effective, especially for trigeminal neuralgia as monotherapy. When I think about non-pharmacologic interventions, I'm thinking about physical therapy, acupuncture, chiropractic manipulation, and cognitive behavioral therapy. So if a person has neck pain that is causing cervicogenic headaches, I will definitely send them to physical therapy. If someone has a myofascial pain that I think might be contributing to their pain, acupuncture is what I will recommend. I haven't recommended chiropractic manipulation so much, but most patients who come to me, even if they don't have facial pain, I will actually recommend that they go to cognitive behavioral therapy. If you're lucky enough, or based on your perspective, unlucky enough to have had a chronic pain or an ankle sprain or an injury, you know that that distracts you from everything in your life. And fortunately, it's a very self-limited time. To imagine that someone has to deal with those types of problems long-term or for the foreseeable future without being able to work, without being able to go to school, is kind of a daunting thought. I think the thing that gets anesthesiologists and interventionalists excited mostly are the interventions. So nerve blocks are some things that we use. We can use nerve blocks as a temporizing measure to help while medications are beginning to work. We can use them for things like occipital nerve blocks for occipital neuralgia. Sometimes we use them for facet blocks, especially for things if a person has cervicogenic headaches, and we move on to something like radiofrequency if we can. Botox is something that we have used, sometimes used more by the neurologist and by our PM&R colleagues for headaches and migraines. The next two, radiofrequency and neuromodulation, are probably two of my favorite modalities to use to treat patients, not only with facial pain, but with any type of problem that they come in to me to see if it's appropriate. I like them because radiofrequency seems to be a kind of a no harm, no foul treatment, because I can do a test block to see if the patient will respond. And if they do respond, I can denervate those nerves with radiofrequency ablation. So I'll describe to you what it is. It's a needle that has insulation around it, except for the tip. And inside that needle, a cannula goes inside, and that cannula is connected to a generator that can actually heat nervous tissue or any tissue. So I can put that around a nerve that is causing painful conditions. I can heat that nerve and really put it out of commission for about 6 to 18 months. And that really depends on the type of radio frequency that I use. There are two varieties. There's conventional radio frequency. The temperature is high. It's 80 degrees. It's a large lesion. We want to have a large lesion because the larger the lesion, the longer the pain relief. The problem with conventional RF is that it can cause some local tissue damage, and there are loss of nerve fibers. Now, pulsed RF, it's 20 milliseconds pulses every half a millisecond. And that pulse allows for the dissipation of heat, so the tissue doesn't get too hot. There's not total destruction. The problem is that it probably only lasts for about 3 to 6 months. And in some cases, insurances say that it is investigational, so they won't pay for it. The other thing that is exciting for me is neuromodulation, and I always talk about David Darrow with that. He is the king of neuromodulation. In fact, when I see him in the OR, I call him Magneto, because that's what he really likes to focus on. Neuromodulation is actually decreasing the brain's perception of painful stimuli by putting some electrical energy near the nerve or decreasing that transmission. There's a couple of ways that we can do that as anesthesiologists or as pain physicians. There's peripheral field stimulation, and so that's something that we used to do back at Walter Reed. So you take a lead, it looks like heavy fishing wire, it has some electrodes on the end, and those electrodes allow you to stop those electrical pulses from getting to the brain. So instead of putting this by a nerve, we just put it in a peripheral field. Some people say that the pain decreases from 9 to 0.75. The reason I'm not so crazy about this form of neuromodulation is because you're not putting it in a described space. There's a lot of lead migration, and there's a lot of chance for infection. Peripheral nerve stimulation is something that's actually pretty new, and it's amazing. Actually, I poo-pooed it initially. There's a very, very small microlead that can be placed around peripheral nerves. And those nerves, I can actually show you a picture of the, how do I go backwards? There we go. I can show you a picture of the equipment. That small needle, I can put it around a nerve with ultrasound guidance. I can leave it there. It has some barbs in it so it won't come out. And there's a generator that will actually communicate with that lead, and it will cause impulses for that lead, and you only leave it in for 60 days. And I said, there's no way that this is going to work for someone who has pain. But I've been very surprised. So I've not ever used it for facial pain, but I've used it for ulnar nerve pain or radial pain. We've placed the lead, left it there for 2 months, taken the lead out. I have a patient who we did stellate ganglion blocks, we did ulnar blocks, and here we are a year and a half later, and he still has pain relief. And so I'm just blown away by the results that we got from that. Go back one slide. The last thing that pain physicians probably do is spinal cord stimulation. So same type of way to think about treating these patients. There's a lead with electrodes on it. This time the lead goes into the epidural space right outside the spinal cord. And there have been some studies that have shown that if you use high frequency stimulation and you put that lead at about the first or second cervical vertebrae, you can have success with treating occipital neuralgia as well as trigeminal neuralgia. Now, I will say that the way that we function in our clinic with trigeminal neuralgia, I say microvascular decompression is the gold standard. At least in my eyes, I will send those people to Andy Grant. But some people cannot have surgeries because they're not healthy enough. They won't survive the anesthesia. And that's when we're able to pull out some of these adjunctive measures, which is why it's important to figure out what all of our colleagues do and some of the tools that we have that are available to us. I had a slide with a picture of spinal cord stimulation, but I think it must have gotten removed from here, so it's okay. Any questions?
All right, so can you pull up the last speaker is Dr. Varun? So our last speaker of the day is Saranya Varun. So I got to know Saranya when she was a fellow working with Dr. Don Nixdorf. And I have to say that, I've had the privilege to work with Dr. Nixdorf for over 14 years now, and he runs a fellowship program for dentists to be trained in orofacial pain. And in my observation of that program, it is the best fellowship program I've ever seen. He commits an amazing amount of time and effort into training his fellows. And Dr. Varun was one of his star pupils, and we had the privilege of working with her in our facial pain clinic, and are now very fortunate that she's remained in town, because it can be very difficult to refer people into the dentistry clinic given their volume. So we've been really grateful that she's remained in town and is an expert in the treatment of facial pain. I always, and I apologize if I'm referring to Don a little bit in your introduction, but we will refer people to Dr. Nixdorf with facial pain, and at times the patients have been upset with us because we're referring them to a dentist. And I've always referred to Don, yeah, he's a dentist, but he doesn't do anything with teeth. He treats facial pain, and that's Dr. Varun's practice as well. So we're really, really lucky to have her in town, and she's going to talk to you today about diagnosis of facial pain from her perspective.
Thank you for such a warm welcome. Thank you, Facial Pain Association, for putting this wonderful panel together. I'm a TMD and orofacial pain specialist, and this is going to be TMD and orofacial pain approach to diagnosing facial pain. Facial pain is pain in the face, teeth, intraoral structures, sometimes coming from neck and head. Multiple ways to define it. ICHT has come up with a way to clarify this. Any pain below, get my pointer working. So any pain below the orbitomeatal line is facial pain. Pain above this region is the headache pain. We all understand that because of the anatomical complexity and neural overlap, diagnosing facial pain condition can be really challenging. And this also leads to patients going through multiple specialties to figure out what the diagnosis is. And as you've heard from the common theme in today's talks, we know establishing diagnosis is the most important part of getting patients the care that they need. Oftentimes, pain is a symptom of an underlying condition. Once we identify what it is, treat it, pain goes away. Not always. Sometimes we don't see an organic lesion causing pain, and that's where pain is the disease itself. About a quarter of the US population experience facial pain in their lifetime. About 11% continue to experience chronic pain, most of which is non-dental pain. The first point of contact for most of these patients is their dental provider. And then it leads to the next step of multiple disciplinaries to figure out where the pain condition is coming from. So to have a common language, because multiple specialties are involved in identifying, diagnosing, and treating pain, International Classification of Orofacial Pain classification came up, modeled on International Classification of Headache Disorders in 2020, to make sure we're all talking about the same thing, same condition, and have common algorithms to treat this. The cornerstone of identifying what we are treating, what we are working with here is a comprehensive history. And this includes talking to the patient about their triggering event, quality of pain, intensity, duration, frequency, what makes it better, what are the aggravating factors, other constitutional signs that they see, and other associated symptoms. Clinical exam, which has to include jaw, TMD structures, intraoral structures, cervical examination, is an important part to identifying what the diagnosis is. Neurological exam should also focus on sensory deficits. Is there hyperalgesia, allodynia, hyperacusis, dysgeusia? All of those things help us identify and hone down on what the diagnosis is. Oftentimes we use chairside testing procedures, looking at dentition, ruling out dental pathologies, doing trigger point injections in a diagnostic setup, doing nerve blocks, sensory testing to help us get to the differential. Because of the amount of psychological distress, the pain, anxiety, catastrophizing, impact in health, impact in sleep quality, quality of life changes, we have patients work with psychology experts to not only help them through the process, but also improve outcomes. Pain broadly can be acute or chronic, can be of multiple different etiologies, like we've heard today, can be traumatic, can be inflammatory, can be cancerous, can come from musculoskeletal structures, neuropathic, neurovascular presentations, and that's what makes this complex in identifying the differentials become really important. So today, we've gone through a few of these subcategories. I'm going to talk about number 2 and 3, myofascial pain and temporomandibular joint pain, and touch a little bit on lesions or nerve pain. Temporomandibular structures include masticatory and cervical musculature, temporomandibular joints, associated structures like the salivary glands, intraoral mucosa, and jawbone, and pain arising from these structures are often seen in our clinical setting. Patients can have multiple different types of symptoms. They can have jaw pain, teeth pain, ear pain, pain behind their eyes, neck ache, headaches, sometimes pressure, tingling, numbness in their face. These are all common presentations. And like we talked about, etiology can also be varied. We use imaging studies to figure out and rule out the most common facial pain condition, which is dental pathology. Dental imaging, like panoramic imaging, can be used to identify dental infection. We use advanced imaging with cone beam CTs and MRIs to look for temporomandibular joint intra-articular disorders. We use brain MRI to rule out secondary lesions like masses in the brain, aneurysms, vascular compressions of the trigeminal nerve, and those things. Salivary gland studies also play a big part. We want to make sure we rule out lesions, tumors in the salivary gland, strictures, adenitis. The cornerstone of TMD management is patient education, to make sure we educate and empower patients to improve on self-management strategies. Physical therapy, use of intraoral orthotics are very helpful. Medication management, acute management with analgesics like NSAIDs, tricyclic and SNRIs are medications used in chronic presentations. Oftentimes surgery is also recommended, although in rare instances to patients who are not responding to conservative treatment. Myofascial or muscle pain is the most common temporomandibular joint disorder. It's oftentimes dull, achy, persistent, annoying, frustrating, can be of varied intensity, can last all day, usually associated with a triggering event, like patient has had a new crown put in or had a recent root canal treatment or tooth extraction. But it can persist over time and chronify, and that case can spread beyond the source of pain, and treatment becomes multidisciplinary. Temporomandibular joint or intra-articular disorders are symptoms like clicking, popping, locking, limited range, swelling in the jaw joints, occlusal changes, facial asymmetry changes. Again, it becomes imperative to rule out inflammatory arthropathy in this case. I won't go in much detail, just for completion, salivary gland lesions, usually parenchymal changes, tumors, cancerous lesions, autoimmune presentations are also important to keep in the back of your mind to make sure it's considered and differential ruled out. I'm going to try and cover this vast topic with a few patients. All of these patients come with a similar chief complaint of face pain or jaw pain. Our first patient is a 55-year-old female who has a recent onset left-sided jaw pain, and this started 3-4 weeks ago. This led to extraction of the lower left back tooth, and the pain has persisted since the extraction and gotten worse. She's gotten newer symptoms since then. She's now noticing paresthesia of the lower left lip. Pain intensity is moderate to severe. Pain is disrupting sleep, affecting quality of life. She's been missing work, not able to spend much time with family. She has a significant medical history. It becomes relevant here because we want to make sure if there are autoimmune arthropathy, we evaluate and rule that out. So the relevant treatment was extraction of 18 3 weeks ago. So panoramic imaging was obtained. Exam showed normal vitals. She's not having signs of fever or lymphadenopathy. TMD, temporomandibular exam, shows limited range, no sign of facial swelling. Intraorally, the extraction site of 18 is not healed appropriately. At 3 weeks' time, you should be able to see extraction site closure and normal healing mucosa. Sensory testing showed altered sensation of the left lower lip. So this is one of those situations where you want to make sure you rule out persistent inflammation. So cone beam CT was obtained. The CT showed delayed healing and low-grade osteomyelitis of the extraction site. So treatment was, as we know, we've identified the cause, remove the cause. So antibiotics, antibiotic mouthwash, surgical debridement, and patient was pain-free in 3 weeks. And we know sensory recovery usually takes a little longer, and she did recover sensory input in that region in 6 months. Case 2 is a 44-year-old female with a chronic headache, jaw pain, neck pain, presentation, some limited jaw range of motion, daily headaches. So no history of trauma. This has been going on for years. Never seek care. Life is busy. She's a mom of 2 kids. Kids need special medical attention. So this is someone we all know in our lives or have been in our lives. She's self-medicating, takes ibuprofen 3 times a day, just gets through her day. Gotten to a point where this is no longer sustainable. She has a medical history of fibromyalgia, has insomnia, poor sleep, and exploring possible sleep apnea diagnosis. The clinical exam, she did have positive findings in temporomandibular exam, limited range, dental wear. The diagnosis was musculoskeletal ligamentous pain of joint and muscle origin. She also has a rebound component to her chronic tension headaches. So management is identifying those contributing factors, daytime parafunction, posture, working on stress management, sleep hygiene, addressing the nighttime parafunction, reducing rebound components with caffeine, moderating ibuprofen, putting her on a short course of muscle relaxant, and she's significantly improved and had a great change in quality of life in about 6 months' time. Case 3, an interesting 14-year-old with ear pain, one-sided ear pain and joint noises, presented with no history of trauma, recent onset, but has been progressive over the last 6 months. Very healthy and active in sports, no family history of any autoimmune conditions. Clinical exam shows limited mandibular range of motion. Ear pain is replicated by TM joint palpation. Oftentimes we see patients with ear pain or pressure, tinnitus, secondary to masticatory and cervical muscle tightness and inflammation. This led us to get her engaged in multidisciplinary care, work with physical therapy, addressing the parafunctional habit, and going on to obtain advanced imaging. The CT ended showing advanced arthritis on the left side. At this age range, when the jaw joint is growing and the growth is not completed, oftentimes CT is completed in conjunction with MRI to make sure we are not missing out inflammation or synovitis. MRI in this patient showed effusion and synovial reaction. This is where we want to make sure we rule out systemic inflammatory markers, although subjectively she didn't have any, so rheumatology referral was higher up on the list. She was diagnosed with juvenile idiopathic arthritis of the left side by the rheumatologist. No other systemic joints were involved. She's being managed by the rheumatologist, is on biological medication to modify the disease pattern. TM joint treatment continues to be with physical therapy, rehabilitation, addressing contributing factors. And once the dental eruption is completed, fitting her with an intraorthotic appliance would be a great idea. She continues to be pain-free. We're monitoring her through her growing stages as TM joint growth completes by early 20s. Case 4, another interesting patient, a 49-year-old male with a long history, a chronic presentation of mid-face facial pain, tooth pain, which started 4 years ago without any inciting event. He had had an endodontic treatment to see if that'll help. Didn't seem to change the pain. Went on to have multiple dental procedures over the years, including retreatment, apicoectomies, extractions, and finally, when the pain didn't resolve, came to see if there are other things that can cause dental pain. He describes pain as a dull, squeezing, pressure pain, moderate intensity, constant all day, doesn't modify with exposure to hot or cold food or biting or chewing. Pain has weather-related triggers, stress-related triggers, which made us think of otolaryngology, sinus type of triggers here. He did have masticatory muscle tightness, cervical muscle tightness, and because of the sinus triggers, the recommendation was to get an ENT evaluation, imaging studies to make sure we are ruling out any dental pathology. Imaging showed nice healing in the extracted site, bridge seemed to be appropriate. Incidental finding of some flattening and arthritis in the TM joint didn't seem to give us the reason for that pain. So the diagnosis was because he had concomitant masticatory and cervical muscle tightness. The diagnosis was referred pain from masticatory and cervical muscles and persistent dentoalveolar pain. Since persistent dentoalveolar pain is a diagnosis of exclusion, we addressed the primary presentation of muscle guarding, and we got him engaged with physical therapy. Did seem to reduce the muscle component, but did not change the sort of neuropathic pain component. So medication management is usually the first line after multiple medication trials. He's seeming to be well managed with pregabalin and is on a long-term follow-up. Doesn't have any more of that constant annoying pain, continues to have those triggers during spring and fall, at which time we put him on an acute medication or increase his pregabalin dose and bring him back to baseline. This is our last case. This is a 75-year-old female presenting with facial pain, the right V2 and V3 area. Started after she had her hip replacement 6 months ago. Pain has a sort of dual presentation. She has a dull, sort of achy pain, limited range, as well as these occasional episodes of sharp pain. So it doesn't neatly fit into any box. She has a chronic history of TMD, chronic history of migraines, both of which are well managed. She describes the sharp pain as severe, debilitating pain, comes and goes, no specific trigger. She's had a few of those episodes, is not constant, doesn't find a pattern to it. Provisional diagnosis, of course, from the previous talk, we know we have to rule out certain pain conditions to avoid missing these diagnoses. So we got blood work to make sure this is not temporal arteritis because it is not the most specific outcome. Temporal artery biopsy was obtained and it was negative. So she was given the diagnosis of atypical facial pain of right V2 and V3 and started on gabapentin. Gabapentin didn't seem to help very much. She didn't feel the best on it. She was noticing fatigue. She was living by herself. The last thing she wanted to do was fall or have disease spells. Clinical exam showed a concomitant TMD, musculoskeletal trigger. She did have hyperesthesia intraorally in that region. She was very particular about tooth number 31 and continued to feel those triggers every time she brushed her tongue around that region. But the tooth seemed clinically normal. We got an endodontic evaluation to make sure we're not missing dental infection. Medical history is also complex in this case. She has a history of stroke. She's on warfarin. Poorly well-maintained high blood pressure, poor sleep. She's recovering fairly from the surgery, very depressed that she's not able to get back to her favorite pastime of gardening and walking after the hip surgery. So there's some psychosocial component to this as well. So we started her with self-care, got her working with our physical therapist, endodontic evaluation, and further imaging to make sure we're not missing an infectious inflammatory component. As expected, number 31 was normal. Bone around that region looks normal. There's no ongoing infection. We gave her a provisional diagnosis of atypical TN because of the concomitant musculoskeletal presentation. We usually with atypical presentation of these sharp shooting pain, getting a brain MRI is recommended to make sure we don't miss secondary findings. So a brain MRI was obtained. She was recommended to get a sleep evaluation. We continue to address her musculoskeletal component and put her on oxcarbazepine, really low dose. Oxcarbazepine also interacts with warfarin and can affect INR. So in this case, we want to be really start low, go slow, and be closely monitoring her. The MRI showed atrophic changes of the right trigeminal nerve, and the superior cerebellar artery was in close association but didn't seem to displace the nerve. So this is one of those situations where there is not as straightforward, this would be the best option for you. So it did bring up neurosurgery consult. She clearly didn't want another surgery. She was now gradually recovering from the hip surgery, and she had started to feel a lot better. She's not having those sharp shooting episodes of pain. She's agreeing comfortably with oxcarbazepine, didn't want to do anything more. We continue to manage her pain and TMD, monitor her labs, monitor her INR, and keep her in a comfortable dose. Usually the outcomes that we expect is pain resolution. So in this case, pain resolution, meaning you alter your medication dose and see if we can get you from a 60% to a 95%. So with that goal, we increased the oxcarbazepine dose with gradual titration, but this seemed to upset her INR, and she was hospitalized for sort of a stroke-like event. So then we went back and forth, kind of got her stable, got her to a place where, okay, this is where we talk about managing expectations, what we can do, how do we modulate the oxcarbazepine, how do we still get you the pain control. Let's try a combination treatment of low-dose gabapentin and a low-dose oxcarbazepine. At this point, she's comfortable. She does not have any more of those sharp shooting pain episodes. The intraoral musculature is the common trigger for this patient, so working with physical therapy has been the most helpful. tool for her, so she can work on her stretches, exercises when she knows she's going through a flare. So desensitization of those trigger zones can sometimes be helpful. This is not for everyone, but some of these patients can present with these specific intraoral musculature trigger points, and in that case, physical therapy can be really helpful. So we know trigeminal pain system is extremely complex. We have input from the jaw, teeth, sinuses, scalp, neck, musculature, ear. So identifying the source of pain so we can direct the treatment in a timely manner to prevent health-related quality of life issues and pain-related morbidity in patients is the primary goal of orofacial pain management. There are multiple different heuristics, algorithms available to, I really like this one. If there's a chronic continuous presentation, usually of a viral component or a neurovascular component, gives us a good set of treatment that has been proven to be helpful. So using these, once we have figured out what is going on, is really helpful. I want to summarize by saying dental pain is the most common facial pain presentation. Temporomandibular disorders is the most common non-dental facial pain presentation. Again, as we have heard multiple times today, working to understand from patients' history and the clinical exam and in identifying what we are dealing with gives us a better chance of treating and managing the pain conditions and giving patients a significantly good quality of life. Thank you so much for your time.